Hello, everyone. Greetings. My name is Jasmeka McCord. I am a neonatal perinatal medicine fellow physician with the Emory University School of Medicine and Children's Healthcare of Atlanta. It brings me great joy to speak with you all again this year, Your Wellness Summit, with a topic entitled Maternal and Infant Mortality. This area is an area of research that is near and dear to my heart, and I'm excited to kind of go through this information with you all. So without further ado, we're going to go ahead and get started. So just disclosures overall, I have no financial disclosures, and the contents of this presentation are of my own research. They don't reflect the opinions of Emory University or Children's Healthcare of Atlanta. They're just my affiliated university and centers. Before we get into the weeds, I do want to discuss some terminology so that we're all on the same page. So infant mortality is defined as the death of an infant before his or her first birthday, so before they turn 1 year old. And neonatal mortality is defined as the death of a neonate within the first 28 days of life. And this kind of just helps us to understand a little bit what the population that we're discussing when we continue. As it relates to maternal mortality, this refers to deaths due to complications from pregnancy or childbirth. So in the perinatal period in which the parent is carrying the baby or during the childbirthing process. And per the World Health Organization, or WHO, the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of the pregnancy. So whether this pregnancy was 4 weeks versus 8 weeks versus 20 weeks does not matter. And whether this pregnancy was intrauterine, meaning within the uterus where babies are normally, babies normally grow, fetuses normally grow, as opposed to in the ectopic pregnancies in the fallopian tubes or elsewhere, does not matter. This still constitutes as maternal mortality. And this is from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes, okay? And then I will be talking about disparities in some of these statistics as it relates to infant and maternal mortality. So I want us to understand the difference between a difference and a disparity. A difference is just what it sounds like when two things are not the same or they're not similar. However, a disparity is a difference that is unfair or unnecessary or unavoidable. Okay. With that terminology underway, I want to talk a little bit about epidemiology because it helps us understand the why. The infant mortality rate is an important marker of the overall health of a society, right? So how we are doing, experts refer to how we are doing as a society with infant mortality as an indicator of that, one of the indicators of that. And so infant mortality rate is in the United States in 2022 was 5.6 deaths per 1,000 live births. And the maternal mortality rate in the US in 2022 was 22.3 per 1,000, but that went down a little bit to 18.6 per 100,000, excuse me, in 2023. I know that these statistics kind of randomly don't help without context. So here we have infant death rates as it pertains to the US. And again, this is a number per 1,000 live births. We are in Georgia, right here in the Southeast. And it is, if you can see, it may look similar with the legend on the side to the darkest blue, but you can see here, Mississippi actually has the highest death rates of infants. They're in that 7.95 to 9.11 per 1,000 live births range. And so Georgia, Arkansas, Louisiana, all of these other states in this darker, not darkest blue area have rates of 6.79 to less than 7.95. So aside from Mississippi still having some of the highest rates in the South and in the nation overall. So this is why it's important. our little state is not leading the ball in what we need to be doing to decrease these rates. And then again, as there are certain key health indicators, as I mentioned before, that kind of help determine what the health of a state is. And one of those rates, one of those statistics that we look at again is the infant mortality rate here. And so I just wanted you all to look at kind of other key health indicators as a context of what the overall health of the state is. In terms of disparities in mortality rates, so we talked about overall what infant and maternal mortality rates are, and then specifically for Georgia, what infant mortality rates are. But this helps us understand what the infant mortality rates by race and ethnicity are, okay? And so this is where there are disparities, because essentially all of these numbers should be the same. If we had equal population that didn't have different disparities or health inequities that populations were impacted by, these numbers would be the same. But here you can see that for non-Hispanic Black infants, the mortality rates per 1,000 live births are 10.9, which is more than 2 times that of non-Hispanic whites. And then, as you can see, for non-Hispanic American Indians or Alaskan Natives, the number is high as well at 9.1, followed by non-Hispanic Native American and Pacific Islanders at 8.5. So truly, this is what drives my passion, trying to understand why these disparities exist to better understand what we can do about them. So now we're going to go ahead and talk about the leading causes of infant mortality. We'll then transition to talk about the leading causes of maternal mortality, and then talk about preventions and interventions that we can engage in to address those. So first, we're going to cover birth defects. The top 5 leading causes of infant mortality are listed on the screen. Birth defects are the first one that we're going to cover. So I don't want to delve too much into this topic. I just want to broach it a bit so that you all can understand that there are specific birth defects that play a role in infant mortality. As a budding neonatologist, I work in the neonatal intensive care unit across different sites here in the Atlanta area. And these are conditions that we see quite frequently. Anencephaly, or being born without a brain, portions of the brain. Cleft lip and cleft palate are, I think, I would say, findings that are more common knowledge amongst the general public. When you kind of have the deviations in the lip and the palate that kind of impact feeding. Hernias, Down syndrome is one of the many trisomies that we encounter. And there are other genetic syndromes that can be related with specific birth defects. And neural tube defects are effects of the spinal cord, and maybe associated with folic acid deficiency. So these are all different types of birth defects that can occur, and again, are just one of the leading causes of infant mortality. For number 2, we're going to talk about, spend a little bit of time talking about preterm birth and low birth weight. We'll kind of talk about them as one. So preterm birth, some statistics as it relates to that. The preterm birth rate declined 1% from 2021 to 2022. That rate was 10.4%, but it did rise by 4% in the prior year from 2020 to 2021. So although you see that 1% decline, we're talking about having a 4% decline the year prior, so a delta change of 3%. But the important thing is that racial and ethnic differences in preterm birth weight rates continue to remain. And then in 2022, preterm birth rates among Black women was about 50% higher than that of white or Hispanic women. And so you kind of think about that in the grand context of what we talked about before, right? How the infant mortality rates are significantly higher among non-Hispanic Black women. And as you can see here, one of those main contributors, preterm birth, are one of the drivers. And there's a disparity in that statistic as well. So when you think about preterm birth risk factors, you want to think about demographics and social risk factors, and then pregnancy and medical conditions, because there's a dyad here that we're talking about, right? You're talking about mom and you're talking about baby, or parent and baby, and how they work together, or how they exist together, they coexist in tandem. And so for demographic and social factors, we find that risk factors including teen pregnancy increase your risk of preterm birth, women who become pregnant over the age of 35. This has been termed a lot of things. Geriatric pregnancies are one of the terms I think we should be leaning away from, but advanced maternal age, more commonly, it should be referred to as. Black women, as we've already mentioned, and then again, consistent with the higher increase of overall infant mortality rates that we saw already. Native Hawaiian and Pacific Islanders, American Indian, and Alaskan Natives. And then women with lower income. So these are the demographic areas that we see higher rates of preterm birth. And then on a pregnancy and maternal standpoint and medical conditions, women who have had prior preterm birth. So if you have already had a baby who is considered preterm, then that increases your risk of having a future pregnancy with a preterm birth. And then women with infection. COVID-19, has been the rage because we're just kind of getting out of that pandemic. But I think that it's important to emphasize that that is not the only infection that increases risk of preterm birth. You have women who have hepatitis B, HIV, other common colds, GI infections, any type of infections can fall into this category as well. Then you have women carrying more than one baby. This is something, as a neonatology fellow, we see very frequently. Women who have twins, triplets, quads, which I have seen, have a higher risk of having a preterm pregnancy. And then women with high blood pressure conditions during pregnancy, which we will cover in later on in this presentation. So next we'll talk about the third leading cause of that being sudden infant death syndrome, or SIDS. SIDS is death of an infant that is unexplained or unexpected. This is in isolation from injuries and which we'll talk about, accidents that we'll talk about next. But this is for babies who die possibly in their sleep or in relation to sleep, suffocation, things like that, that need to be investigated. And so you may have realized or may be aware that there is a big Safe Sleep campaign going on to reduce our rates of SIDS. It's completely devastating. This is not in association with prematurity like we talked about before. Some type of chromosomal abnormality has nothing to do with that, and which is why in part I think it can be a little bit more devastating, because the effects can be detrimental and just so unexpected and very difficult for our parents to recover from. And so the Safe Sleep campaign has been employed so that we can do our best to minimize the risk of having babies that die from SIDS. So listed here, we have some of the components of the Safe Sleep campaign that kind of help disseminate those or decrease those risks related to increased SIDS. So putting your baby on their back to sleep for all naps and at night. I cannot emphasize this enough. My disclaimer is that I'm a mother of two who are, both of my children are under the age of 5. And so I am not far removed from this. I know what it's like to have a baby that's up all night, that you're trying to navigate getting your own sleep and being so fatigued, but needing to take care of their needs as well. And so it's so easy to try to get them to sleep in the best way that the best way that they fall asleep. And oftentimes that is on their belly, right? You put babies on their belly, you pat them on their back or butt, and they just seem to be well soothed in that manner. And while that may be easier and much more convenient from a parental standpoint, it is definitely not safer. And so we want to emphasize putting babies on their backs to decrease their suffocation risk for all naps, for all feeds, for all sleeping. Oftentimes, babies may do tummy time, and we encourage tummy time, and we want them on their belly so that they can exercise those head muscles and get strength in their head. However, in the moment that the baby falls asleep, they need to be transitioned back to their back, okay? Back to sleep is the campaign to help us remember how they should be sleeping. In the hospital setting, we often talk about how there may be delays to skin, and safe sleeping is not to replace skin to skin. We encourage skin to skin. We want our babies, as soon as they come out the womb, to be placed on the birthing parent and have that time for bonding and thermal regulation and all of the wonderful things that constitute skin to skin. But afterward, if mom is sleepy, if mom is tired, if for any reason baby needs to be put down, they need to go back into the bassinet on their back, no incline. There should not be anything in the bassinet or the bed with the baby, no blankets, no pillows, no stuffed animals, nothing that could possibly obstruct their airway and cause them to suffocate. And then nothing that lifts them up off of a flat surface as well. In the NICU, our disclaimer is we may put our babies on their bellies temporarily, because there are a number of reasons why that may be more appropriate for premature babies in that time. However, once they are stabilized from an acuity standpoint or stabilized from whatever pathologies have placed them into the NICU, then we want to work on transitioning them to home. And at that point in time, we employ safe sleep measures in the NICU. So you'll see for our, not even necessarily for our older babies, but just for our babies who are closer to going home, we make sure that we're starting to employ safe sleep measures and putting them back on their backs. I do want to mention once we get babies to rolling over, because this is a major area of, I think, stress for parents who do really want to make sure that they are practicing safe sleep. Once a baby is able to roll over, then we don't have to start going into the crib and putting them back on their bags. At that point in time, they have developed the skill to be able to roll over. So the likelihood that they will suffocate just from rolling over is low. And I think it's important to recognize that it's much harder for a baby to roll from their backs to their bellies than it is for them to roll from their belly to their back. So if they are being placed on their back and they're able to make it from their back to their belly, then it is more likely that they will be able to safely roll back onto their back when they need to, if there's for any reason, some type of obstruction of breathing. So I think it's important for us to understand that we should continue to place our babies on their backs to sleep, but once they start to develop the rolling, then you don't need to go back and continue to turn them over throughout the night. Rest comfortably, knowing that is a low likelihood that they would suffocate at that point in time. I mentioned using a flat surface, but it should also be firm. I know for adults, we may often like to sleep, lavishly with our pillows and cotton top mattresses and all of the things that are nice and soft and comfortable, but it's important for us to understand that we should be putting babies on firm surfaces so that they don't sink into the mattresses, which would be a suffocation risk as well. I would also emphasize other objects that I talked about already. Nothing else should be in the bassinet or crib, no loose bedding. But I really, really want to spend some time talking about bed sharing and room sharing. Going back to the original comment that I made about what's more convenient from a parent who is sleep deprived and tired and all of the things that comes along with having a newborn baby or an infant. Oftentimes our parents may resort to putting the baby in the bed with them, and that is referred to as co-sleeping. And I have to emphasize that the American Academy of Pediatrics, which most pediatricians and subspecialists follow for recommendations for what we should be offering, the advice we should be offering to our parents, is that we should not be co-sleeping with our babies and putting them in the bed with us. Trust me, I get it. I know what it is like from my own experience. But what is most important is the safety of your little one We do not want to have any accidents that occur because someone accidentally rolled over to the baby in the bed, or the baby, again, all of the things that are not supposed to be in the crib or the bassinet, you know, those soft pillows and blankets and sheets and all of the things that the baby suffocates because of their exposure to that. I just cannot emphasize that enough. We do encourage room sharing. And what that means is that the baby is safely asleep inside of a bassinet, even if it is a bassinet that attaches to the bed that is at this point in time fine, or in a crib inside of the same room so that you can be attentive to their needs. But we do highly recommend against bed sharing and co-sleeping. So that was it. So far we've covered birth defects, we've covered preterm birth, we've covered sudden infant death syndrome, and now we're going to transition into talking about unintentional injuries. So for car accident prevention, there are so many unintentional injuries that can occur, but I want to focus mainly on car accident prevention and drowning prevention as the two that we're going to cover in this presentation. For car accident prevention, we want to make sure that we know that all children less than the age of 13 should be in some type of restrained seat support while they're in the car. And this diagram that I attribute to the CDC does a great job of illustrating the different stages and ages that are appropriate for specific types of car seats. So all infants coming out, unless there are specific circumstances, should be in a rear-facing car seat. And what this means is that it's typically an infant car seat or a convertible car seat that is rear-facing, meaning the baby is facing toward the back inside of the car seat. They should be in the back seat, not in the front seat. And this rear-facing car seat is typically suggested until around the age of 2. The caveat is that each manufacturer has different recommendations based off of the safety procedures and mechanisms that they employed for their specific car seats. And so you really should follow the guidelines that are listed on those car seats for the ages, for the heights, and the weight specifically for children. But I would say around 2 years old is when we say that transition can safely occur from rear facing into forward facing. But again, it's specific to the car seat. So that should be from age 2 to 4, especially if the infant is happy and fine in the car seat and not giving any issues and they're rear facing, then that is going to be the recommendation. The reason why this is the case is because while, again, our babies don't have all the head control and all of the musculature and development to properly support their necks, they are very, very prone to whiplash that may occur when a car is rear-ended, which is the number one mechanism of injury in car accidents. Because the baby is in a car seat facing backward, when they are rear-ended, their heads go backward into the seat, and so they don't have that whiplash injury, which is the most safe mechanism. However, if a baby is in a forward-facing car seat and they're too young, and still not having achieved the appropriate support from their body to be able to support their head and stay backward, even adults face whiplash, right? So if they're facing forward in a car and the car is rear-ended, then they have that whiplash injury, and it can just be extremely detrimental to our baby. So that's where that recommendation comes from. At the point in time where they're able to face forward, this is literally just a change in the direction of the car seat, not a change in the car seat itself. Okay, so this is after a child has outgrown their rear-facing car seat, they should be in this forward-facing car seat, again, based on the maximum weight or height limit of the car seat, that specific manufacturer. Now, once we get into kind of, after I would say 5, 6 years of age, then we start to talk about our booster seat range. Now you can see that the car seat structure changes. This is when you don't necessarily have to have that four harness, where it can just kind of be the seat belt that is in the car that can just be applied to that child while they're in that booster seat, What it does, the booster seat, it just gives them the additional height that is needed to have the seatbelt safely go over their chest in their lap as opposed to in their neck or over their face. So that should be a buckled in booster seat until, again, around 9, 10, 11, where the child can achieve ideal height. And be transitioned safely into a seat belt. And this is, again, just when the seat belt fits them properly. That variation in age is really going to be different based off of the individual child and their height. And so, again, based off of not only manufacturers' recommendations, but pediatrician-specific recommendations for the individual children. And these mechanisms are extremely effective at minimizing injury when you're in a vehicle. And I have personally have treated infants or children who were unrestrained in car accidents or have been impacted, on the road. You have the fatal accidents that, there's standstill traffic, that they're trying to find the child who's been propelled out of the vehicle because they weren't properly restrained. And these are little things that we can do that have high reward. So just take the time to properly restrain your children. The other accidental injuries that I want to focus on is drowning, especially as we are now in the spring, transitioning into the summer, where it's the warm months. We certainly see an increase in the amount of ED visits and hospitalizations and ICU stays as it relates to infants or children who are victims of drowning. This is so important. As you can see here, the disparity exists as drowning death rates for Black people under the age of 30 are 1.5 times higher than the rates for white people. And then for drowning disparities amongst children specifically, they're highest among Black children aged 5 to 9 and those aged 10 to 14. So not only does the disparity exist there, but the rates are just entirely too high, and we have to do our best to address these rates and prevent drowning. I want to talk about the fact that drowning is not just something that happens in large bodies of water, right? It's not just something that we see in the beach or in lakes or rivers or in the pool. We often see drowning from, if there are infants or very, very small children, that can occur in the sink, that can occur in the tub, that can occur in the small kiddie pools. And we need to do the best that we can to minimize this risk. And so the AAP certainly has endorsed recommendations, those including learning basic swimming and water safety skills. We're not trying to raise Olympians here. We are just trying to teach survival. For my children, specifically my daughter, she's in swimming lessons, and they really emphasize what to do if you find yourself falling into the water, how to fall in and turn around and find the wall and hang on to the wall, or find the railing, or swimming safety mechanisms, like should you be in the pool by yourself, or what happens if there's no adult around. And these are the water safety skills that we want to teach so that we can decrease the mortality as it relates to drowning. What we can do as adults is make sure that if we have pools in our backyards, whether they're above ground or underground, that we make sure that we have fences that fully encloses those pools, and that we're checking in as our children continue to grow to make sure that these children do not know how to unlock these gates, right? Once these toddlers, at a point in time, my kids didn't know how to open gates. And then as they grow and they learn and their dexterity gets better, they're able to open these gates. And we have to make sure that we're checking in to make sure that they can't access those gates because they don't know the dangers that lurk. Sometimes even as much as we say it, they see the pool, they see fun, and they get in and they go. And too many times, we turn our head for a second, or we just walked away for a minute, and our babies are found face down in the water for unknown periods of time, and it can be fatal. And so we want to do what we can to prevent that. As I alluded to, supervising closely is very important. Walking away from your children when they're in the water is a big no-no. Oftentimes, sometimes even being on your phone or reading a book. When children are in the water, it's just not the time for leisure. It's the time to be more active or even in the water. If you're being out of the water is fine, but if you're in the water, we want to just always be present and engaging with them so that they can be supervised closely. Wearing life jackets for children, and this is apart from when they're doing lessons, right? When they're doing lessons and there's an adult with them and watching them and engaging with them, or even when you're just trying to teach them on your own, that's fine. But wearing a life jacket, if someone's not going to be directly in the water with them, or even if they are, is very helpful. And then from a parental standpoint, or from a water watcher or caregiver standpoint, learning the basics of CPR, that should be employed when all other mechanisms fail so that we can intervene as quickly as possible. And lastly, we want to cover maternal pregnancy complication as a leading cause of infant mortality, and that's going to help us transition nicely into talking a little bit more about maternal mortality. So pregnancy complications for pregnant women with pre-existing diabetes, high blood sugar around the time of conception, this increases your risk of health problems, including birth defects, stillbirth, and preterm birth, and overall NICU stays in relation to these conditions. And so that's why pregnancy complications can impact babies as well. As it relates to chronic and gestational hypertension, I want to spend time talking about this because this is so common. We so commonly in the NICU see babies who are born early as a result of hypertension in pregnancy. I want to emphasize the difference between chronic hypertension and gestational hypertension. Chronic hypertension is hypertension that exists prior to the 20-week mark. So if you've already been diagnosed with hypertension and then become pregnant, and if you have not been diagnosed with hypertension prior to pregnancy, but you develop it prior to the 20-week mark, that constitutes as chronic hypertension, whereas gestational hypertension occurs after the 20-week mark. But both of these types of hypertension can result in preeclampsia, so they are important. Just want us to be able to distinguish between those two. Preeclampsia develops, or preeclampsia is hypertension with other markers such as protein in your urine, significant swelling or edema of your extremities, or other markers. And this happens if you suddenly develop high blood pressure and protein in the urine after 20 weeks of pregnancy. But again, you can still have chronic hypertension and get preeclampsia. High blood pressure increases the risk of preterm delivery, like we've already mentioned. It increases the risk of low birth weight, eclampsia, which is the development of seizures in the setting of high blood pressure and the other findings, and stroke. So let's talk a little bit about maternal mortality. So as you can see listed here, we have in our blue graph 2022 statistics and in our green graph 2023 statistics. And you can see among some population, the numbers have declined, and others, they have risen. And so deaths per 100,000 live births, we can see that, again, non-Hispanic, Black individuals have the highest disparities as it pertains to maternal mortality, almost 50 per 100,000 live births in 2022, and exceeding that number in 2023. And then the rates are followed by non-Hispanic whites, and they're kind of overlapping with the Hispanic population. And then lastly, we have our Asian population with the lowest rates. But again, these rates are too high overall, and we need to do everything that we can to address them. For leading causes of maternal mortality here, we have mental health conditions, hemorrhage, cardiac and coronary conditions, infection, thrombotic embolisms, and cardiomyopathy. For the sake of time, we're just going to focus on the first three because these are what I most commonly see in my practice, and we want to talk about what we can do to kind of intervene. So first, we're going to focus on mental health conditions. So mental health, this includes a myriad of different illnesses, psychiatric illnesses, but we're going to focus on depression and anxiety as they're the most common. Anxiety disorders are common, again, before, during, and after pregnancy. If you have an anxiety disorder, you may struggle with uncontrollable feelings of anxiety, nervousness, fear, worry, panic. This area is something that I feel in recent years has grown more interest in studies in the literature, because Oftentimes we would just focus on depression, but now we are seeing that there are more women who have complaints of just significant anxiety as it pertains to their pregnancy. They feel that someone's going to harm their baby. They feel very much so out of control. And these are something that this is something that we're starting to pay attention to a lot more and address. As it pertains to depression, this is during pregnancy, it can make it hard for you to care for yourself and your pregnancy or your baby. Having depression before or during pregnancy is a risk factor for postpartum depression, which occurs after pregnancy and after the birth. I think it's important to distinguish between postpartum blues, where you may have intermittent feelings of sadness or fatigue, or you're just tired, which can be attributable to the fact that you just had a baby, and now are dealing with those hormonal changes, but also just the difficulties as it pertains to caring for a newborn, which can be distinguished from postpartum depression, where those factors are significantly contributing to inability to function or are causing you to have harmful thoughts for yourself, your baby, or others. Either way, whether it's anxiety, whether it's depression, this falls under mental health and is a major contributor to maternal mortality. And mental health conditions were the leading underlying cause of death among Hispanic and non-Hispanic white women. And what you'll see is that under these different causes, we'll see how they impact the different races and ethnicities differently. But mental health specifically is the leading underlying cause for Hispanic and non-Hispanic white women. Now we're going to transition into talking about hemorrhage. And so I have depicted here an image of an episode of the show The Resident, which I do not watch. I am, in medicine and living it, so I try to stay away from these shows as much as possible. But my husband is watching the series, and he said, Jazz, you really have to watch this episode. I was infuriated, and he was just so upset. And so I watched it. And essentially what happened is in this episode is you have this resident here in the green scrubs with the ultrasound jelly on the pregnant mom in the setting of her partner with her, who is hearing these complaints of this mom who essentially had to undergo a C-section for reasons that I cannot remember, but he saw the baby and was checking in on the mom just because he kind of developed a relationship with this family and noticed that she had complaints of just kind of feeling fatigued or just discomfort, which at first glance you can just say, well, you just had a baby, so it's probably in relation to that. But then she just, he paid attention to the vital signs. They were starting to tank, and she just looked ill appearing. And she had this catheter that was like significantly bloody, which you should not see after a routine cesarean section. And so long story short, it escalated to where she had to be taken back to the OR, suffered significant hemorrhage because this process was very much so delayed as the complaints or the concerns were not seen as appropriate or validated in this family. And so hours went by, and she just had significant bleeding and ultimately died as a result of the complications of this surgery and the neglect of the patient's concern. And so hemorrhage in pregnancy and peripartum is a significant cause of mortality. And I think that we've seen in the media a lot more in terms of unfortunate circumstances where patients' concerns were just not addressed, where patients were gaslighted, where all types of things resulted in a lack of immediate care, and unfortunately resulted in the lives lost of these mothers and parents who had recently delivered. And this woman in this episode was not non-Hispanic Asian, but it's important to note that hemorrhage was the leading underlying cause of death as it relates to non-Hispanic Asian women. So all that to say, we need to pay attention to the concerns of our parents and their partners. We need to make sure that we're doing our due diligence and checking in on these patients and doing the difficult work of distinguishing between what can just be seen as a common complication and something that is truly abnormal. And lastly, I want to spend some time talking about cardiac and coronary conditions and a little bit in myopathy. So cardiac and coronary conditions were the leading underlying cause of pregnancy-related deaths among non-Hispanic Black women. Cardiomyopathy risk factors include alcohol use, doxorubicin use. Doxorubicin is an anti-neoplastic or an anti-tumor drug, so a cancer drug that can result in, again, cardiomyopathy. Abuse of drugs such as cocaine and methamphetamines. All of these are risk factors for having cardiomyopathy. Coronary artery disease risk factors are those that expose individuals to ischemic heart disease. That includes hypertension, which we've talked about. And if you could imagine, you're thinking about, your heart trying to pump blood to these arteries that are significantly stiff, possibly as a result of prolonged hypertension, and they're not able to have adequate blood flow to your essential organs, and that leads to ischemia and just overall coronary artery disease. Hyperlipidemia and hypertriglyceridemia, that's when your cholesterol levels are higher and you may be on a statin therapy to kind of control that, or you may just be diet controlled. All of those things that can maybe clog your arteries and again impede blood flow to these areas and result in ischemia or stroke. Diabetes, obesity, smoking, immobility, all of these things kind of have similar pathways to impacting your heart's ability to function in terms of getting adequate blood flow to these organs, and again, contributes to coronary artery disease, which results in ischemia. And so all of these are risk factors. Pregnancy-associated myocardial infarction is thought to be contributed to by preeclampsia and eclampsia. So again, in those moms or those parents, pregnant parents or pregnant people who have high blood pressure in the setting of other findings may have heart attacks as a relates to that. And then valvular disease can be exacerbated just by hemodynamics of pregnancy. You may see different murmurs. We have different amounts of flow. You have significant volume overload as you have to compensate for the baby as well. And all of these can contribute to valvular disease. So now that we've kind of talked about the leading causes for infants and maternal mortality, and we've talked about the disparities that exist, what's important is talking about what we can do to first prevent this from happening, and then what we can do to intervene when this has occurred. So prevention is just so undervalued in medicine. It's underfunded. It's just the research that goes into it is just so important. And I just want to emphasize that we should really be talking about what we can do to prevent, because once the disease has manifested, now we're reactionary, right? We have to be proactive to address a lot of these conditions, and reactive only when our proactiveness has failed us. So antenatal care, so making sure that we are emphasizing that our patients should be receiving regular, routine care. That's prenatal checkups, early detection of pregnancies, so that we can appropriately manage them is going to take us a long way. And even in the antenatal care, same umbrella, family planning. So making sure that we are having visits that address if it's in our goal to have a pregnancy, right? And what we can be doing prior to the pregnancy to be able to maximize our chances of having a healthy pregnancy and reducing infant and maternal mortality. We want to, and I recognize fully that there are many different birth plans out there that exist. And sometimes a hospital birth is not what is in the best interest of our mother, our parents, our birthing parents who have their own plans that they would like to follow. And I think that within reason, that is fine. But we want to make sure that these births are attended by trained healthcare professionals, whether this is in a hospital setting or not, so that we can reduce the risk of complications. Can home births be successful, or birthing center births be successful? Absolutely, 100%. We just want to make sure that we have the skilled individuals there necessary to intervene in those instances where birth plans do not go as followed. And in the instance that they don't, we have access to obstetric care likely in a hospital setting, to be able to intervene quickly and appropriately. I recognize fully that abortion services are becoming more and more limited with our changes in policies from a local, state and federal level. And so that is really, really causing a lot of challenges as it pertains to how we care for mothers, for planned abortions, for spontaneous abortions, or even for how we care for our babies in the instances where our moms don't survive. And so this is just a growing level of challenge, and we are really trying as health professionals to minimize unsafe abortions. And because changing policies does not mean that abortions are going to stop. It just means that our access to safe abortions are going to decrease, and we will just have a higher amounts of unsafe abortions, which we don't want. So trying to access safe services is what is important. Continuing prevention, we want to address social determinants of health. That is a whole other lecture and conversation in and of itself. But those social drivers of health, the things that we don't often think about that may directly impact your health, meaning access to care. What are your living conditions looking like? Do you have safe neighborhoods? Are you significantly exposed to violence? What is your education level, income level, things that you may not directly think impact health, but studies have shown that these things are significant impactors to our health quality. And so we want to make sure that we're paying attention to these areas to emphasize prevention. Postpartum care, which is providing ongoing ongoing care after childbirth to manage complications as it relates to infections and bleeding, which we've mentioned. And then nutritional interventions. What are we eating? What kind of nutrition do our pregnant women have access to beyond what we're eating? What kind of supplementation are they taking? Kind of when I spoke earlier about neural tube defects, this is something that can be highly preventive with appropriate folate supplementation. So do we have the appropriate access to nutrition and the medications that we need or vitamins that we need to ensure maternal and fetal health? There are a number of interventions and collaborations that have been very much so vetted and exist that I just kind of want to touch on. The perinatal quality collaboratives or PQCs, they're state or multi-state networks of individuals, healthcare providers who want to improve the quality of care for mothers and babies. They identify healthcare processes that are in need of improvement and suggest the methods to make those improvements happen as quickly as possible. They contribute to improvements in healthcare outcomes specific to reducing healthcare associated bloodstream infections in the newborn. That's talking about in a hospital setting. We're talking about reducing severe pregnancy complications associated with high blood pressure and hemorrhage that we've mentioned, screening and treatment for substance use disorders, building connections between hospitals and communities. I think I want to emphasize the importance of communities working in tandem, right? It shouldn't be one entity versus one entity. We all have unique strengths that we can offer to our mothers and their babies, or our parents and their babies, to help them. And what I may not be able to offer, I may have a community organization that I can refer patients to be able to get the support that they need. Addressing maternal mental health care, ensuring use of maternal's milk, which I will talk about in a second, but these are interventions that exist. I do want to show this short video from the PQC to kind of help talk about what they do and how their interventions
It's
are helpful.
important that all pregnant women and newborns receive the best health care. This helps women have healthy pregnancies and their babies get a healthy start in life. Perinatal Quality Collaboratives, or PQCs, are clinical teams and public health leaders working together across the state to improve the quality of care for mothers and their babies. To help them accomplish their goals, PQCs partner with key state agencies and organizations, including hospitals, health departments, health professional associations, universities, state chapters of nonprofit organizations, health insurance organizations, and state Medicaid agencies. PQCs also partner with the families and communities they serve. How do PQCs work? PQCs often start by selecting projects that address major health problems for mothers and babies in their state. Then, they follow 3 steps to successful quality improvement. First, they recruit multiple hospitals across the state to participate in the project. Within each hospital, they empower multidisciplinary teams to apply various tools to quickly improve healthcare practices. Second, PQCs rapidly collect, analyze, and share project results with participating hospitals. This helps hospitals view their progress and compare it to other hospitals. Tracking progress helps hospitals identify opportunities for improvement and make changes as quickly as possible. Third, PQCs facilitate collaborative learning. The hospitals participate in educational webinars and learning calls to review their data, share best practices, and discuss opportunities for improvement. The number of state PQCs has grown considerably over the last decade. Most states now have active PQCs in various stages of development. PQCs have helped improve healthcare and outcomes for moms and their babies across their states. Some examples of PQC successes include reducing unnecessary medical interventions, such as early elective deliveries, reducing infections in the neonatal intensive care unit, or NICU, and reducing severe pregnancy complications. CDC provides support to PQCs to improve the quality of care for moms and their babies, works with experts to develop tools PQCs can use to further their development, and supports the National Network of Perinatal Quality Collaboratives to serve as a resource for PQCs across the country. Learn more about how to develop and support PQCs at our website.
Again, I just want to emphasize for the PQCs that they really take an evidence-based approach, and it's important to have a process system that addresses these concerns. We don't want to just throw things out there and kind of without having a system that is important. So having these PQCs that go through a methodological approach to addressing these concerns is just necessary and extremely beneficial. And lastly, I just want to talk about PRAMS. It's a pregnancy risk assessment monitoring system. This is a survey-based system that allows for parents who have recently given birth to discuss their experiences. And what they will do is they reach out, ask mothers questions about their pregnancy, their new infant, and it gives information to help us learn more about the impacts of health and certain behaviors that may, affect outcomes. And so I think that oftentimes we shy away from surveys, but surveys can be a very powerful tool to help us gather the information that we need to make adequate change. Lastly, I want to discuss the interventions as it pertains to breastfeeding. This is my number one area of interest. I am a breastfeeding mom of 2 and just finishing up my breastfeeding journey of my second child. And I have had significant challenges, but for sure, I can attest to the benefits for the baby and for the breastfeeding parent. And this is proven to impact infant and maternal mortality by decreasing those rates. So this chart here by the Prenatal Perinatal Network discusses the benefits for the baby. These are just a few of the many things that are beneficial. That includes the best source of nutrition. We know that human milk is superior to formula. It decreases risk of SIDS, which we've already talked about being one of the primary drivers of infant mortality, helps develop a strong immune system and prevents illnesses that and the likelihood of infections, of ear infections, stomach bugs, intestinal infections specific for our neonatal intensive care unit babies, lowers risk for obesity and type 1 diabetes later on in life. And for moms, it decreases the risk of breast cancer, ovarian cancer, type 2 diabetes, and high blood pressure, reduces the risk of postpartum depression, and when you look at this image, I mean, I just see, this parent who is enjoying, again, emphasizing the bonding that is present in this dyad, and being able to successfully feed and console and bond with this baby and provide skin to skin. When you think about that, it's just really possible to imagine how this could be reducing your risk of postpartum depression. Now, that does not mean that this is a roses and lilies process. Breastfeeding is hard work. It takes commitment. It's often can feel like solitary because you're the sole person who can provide that nutrition for your child. So I do not mean to express that this is something that's just going to be such a positive experience, and so that it can minimize your risk in that way. And on the contrary, I think it can also contribute to some challenges that you may have with feeding, but it does create a unique bonding experience for the breastfeeding parent and the baby, that I feel is invaluable. It aids in return to pre-pregnancy rate. Breastfeeding helps save a lot of money because you're not buying formula. The benefits are truly, truly remarkable. And I just want to emphasize that we can see a reduction in mortality rates for both mom and baby. So in summary, we know that infant and maternal mortality rates remain high, that there are disparities amongst different racial and ethnic groups as it pertains to infant and maternal mortality. There are prevention strategies that can be implemented to maximize safety of mother and infant and minimize those disparities. And there are evidence-based interventions that we can utilize to minimize the mortality risk as well. And lastly, breastfeeding has health benefits for both moms and babies, or parents and babies. I'm trying to use gender neutral terms. It's very difficult when gender normative terms have been ingrained in your brain. But hopefully this was helpful information. Hopefully I have done a good job at summarizing the infant and maternal mortality rates and the disparities that exist. If this were a live presentation, I would open it up to questions. But as it is not, I wanted to list my contact information there. I would greatly appreciate your feedback, your questions, your comments. And these are the references that I use. Thank you all so much. And I hope you all enjoy the rest of the summit.